So my name is Salomon Manier. I'm a professor of hematology in Lille University in France, and I'm focusing on multiple myeloma. So we've been discussing about the management of elderly patients, and I think it's an interesting period of time for this population of patients with multiple myeloma because there is some important changes in the way we treat them. So far, at least in Europe and the US, the strong standard of care for elderly patients is the MAIA regimens, so the combination daratumumab, lenalidomide, dexamethasone. We used to treat all the patients in the same way, all the patients who are transplant non-eligible with the same treatment. And now we tend actually to divide this population of patients into different subgroups based on mostly frailty, sometimes age, and to treat them differently among the different subgroups. So for that, actually, we need frailty scores that are applicable to clinical practice, and that's also something important to develop. The last recent studies we had for elderly frail patients is the IFM 2017-03 phase 3 trial. We removed dexamethasone, try to avoid toxicity and infections specifically in those frail population of patients. We had interim analysis and we should have soon the final report of the study. So probably an interesting strategy to stop very early after only 2 cycles dexamethasone in those elderly frail patients. If you consider the elderly fit population of patients, we had the report of 2 big phase 3 studies, IMROSE and BENEFIT, this year at ASCO. Both are exploring the quadruplet regimen with isatuximab and VRD, bortezomib, lenalidomide, dexamethasone. This, in both cases, in elderly and fit population of patients, and patients above the age of 80 years old were excluded. We observe a clear benefit. In IMROSE, it's against VRD. In BENEFIT, it's against Iza-Lendex. We see a clear benefit of the quadruplet regimen in terms of PFS for IMROSE, in terms of MRD negativity rates for benefits. So probably that this will be the next standard of treatment for this elderly fit population of patients. So that's a clear improvement for their outcome. The quality of life is preserved in those patients. So that's a significant step forward. Now, if we consider the new generation immunotherapies, there are ongoing trials. So we had just some very early data of Majestic 7 with teclistamab, the BCMA CD3 bispecific antibody in this elderly population of patients combined to daratumumab and lenalidomide. So it was the safety run-in of Majestic 7 with 26 patients who were reported. The efficacy is remarkable. Almost all patients respond. The 1-year PFS rate is 96%, which is obviously remarkable. Safety-wise, the data are quite encouraging. It's 30% of grade 3-4 infections in those patients, and mostly within the first 3 months. So it's critical to apply all the prophylaxis possible for those patients to prevent as much as possible the early risk of infection. And then there are ongoing programs. The phase 3 magnetism 6 with elranatamab is ongoing, and CARTITUDE-5 is also a phase 3 trial in elderly patients comparing RVD to RVD and cilta-cel, the CAR T cell targeting BCMA. We'll see it's an interesting strategy, but in the experimental arm with the CAR T cell, it's a fixed duration treatment, which is very interesting because it's usually not the case for elderly patients because we used to treat them as continuous treatments. So interesting to have to explore with this new generation immunotherapies the possibility to stop the treatments in those patients.